Okay, colleagues, thank you for joining the global webinar on vaccine inequality. Till other colleagues join, let us start. It's already 3-4 minutes late. Hi, I'm Pradeep Besak. I'm from GCAP. I'm the Asia coordinator. I welcome you to this vaccine webinar where we'll basically be discussing broadly giving a overview of the vaccine inequality at the global level. You may know that we as People's Vaccine Alliance, GCAP, and other colleagues, we have been continuously working for last more than a year now, on this issue, addressing vaccine inequality. Some of our effort has brought colors. The rich countries have budged on some counts, at least the US has accepted that there should be intellectual property waiver on vaccines. Now, European Union has appreciated or acknowledged at least that intellectual property is a barrier for vaccine inequality, despite all our effort and rich countries accepting at least at the policy level, at some level. The vaccine inequality continues. Rich countries have now vaccinated, say 70 to 80% people are vaccinated. On the other hand, countries like Africa, we have only 11% vaccination. In a recent leaked text, which is a proposal given by EU and the US. They are in negotiation with India and South Africa, who had initially proposed for TRIPS waiver of vaccines, COVID vaccines test and treatment. We see that it's way below expectations. In this background, let us discuss the current vaccine situation now. We'll have speakers will essentially enlighten on this technical subject. We'll also do the regional presentation. We'll try to know how is the vaccine situation in different regions in Asia, in Africa, in LAC, and Europe. Then we'll be presenting a draft GCAP plan. We have been working for last year. We did quite some work in 2021 and did also some work this year. But we'll be sharing that draft plan for GCAP. Please contribute to strengthen that. So welcome you all. Before I hand it over to Becky Malay, the former co-chair of GCAP and GCAP Philippines, to moderate the session, I invite my colleague Johannes to tell us about the interpretation facility that is available. Johannes?
Thank you very much, Pradeep. Just a short technical announcement about the interpretation, also in French and Spanish, so people who might not speak English also understand how to access the interpretation feature. Donc, bonjour à tous et toutes. J'aimerais bien informer vous qu'on a disponibilité de l'interprétation. Il y a une petite icône, un petit monde en bas dans votre menu où vous pouvez choisir la langue préférée que vous voudrez écouter en cet webinaire. Et si vous avez des questions, vous pouvez contacter dans le chat pour quelque chose que ne fonctionne pas. Merci beaucoup. And now just in Spanish. Muy buenos días a todos y todas. Quisiera brevemente compartir que tenemos disponible la interpretación en inglés, en español y en francés también. Si ustedes ven un pequeño mundo, un icono pequeño que está abajito, ahí pueden hacer clic y elegir su lengua favorita para escuchar toda la sesión. Mucha suerte, muchas gracias y disfruten.
Okay. Thank you, Jonas. Friends, you can also simultaneously tweet. I share 2 hashtags, People's Vaccine, TRIPS waiver. Whenever possible or applicable, you can tweet. People's Vaccine, in fact, hashtag People's Vaccine is something you can tweet. And you can tag us at Whiteman. Thank you. Becky, over to you for moderation.
Okay, good morning, good afternoon, and good evening to everybody. This is Becky Malay. I am the convener of GCAP Philippines and former chair of GCAP. I'm very happy to be part of this discussion, this webinar on vaccine inequality. And I'm very happy also to be part of the People's Vaccine Alliance, which has really made a lot of strides in terms of really pushing the advocacy towards more systemic issues that really affect our not only the availability of vaccines, but the well-being of everyone in this world because of COVID. No, so I'd like to introduce to you our first speaker, who is the Global South convener of the People's Vaccine Alliance. We have Maza Seyum. Maza is an Ethiopian feminist who has been working in global health for close to 2 decades. Maza recently joined the PVA as Global South convener. And in this newly created position, she will be supporting, linking, and amplifying the work of the Alliance members in Africa, Asia, and the Caribbean and Latin America. And she's striving to place the Global South firmly at the center of all health and health equity discourse. This is very important, both in the response to this pandemic and in preparation for future pandemics. So without further ado, welcome Maza. Go ahead with your presentation. Thank you.
Thank you so much, Becky. I really appreciate it. And thank you to GCAP. As Becky has said, this is a new position for me. I know some of you, Kavengo, Pradeep, Ingo, from when I was at the African Alliance, which is the home of the PVA in Africa, but I've just joined the People's Vaccine Alliance not even 2 months ago. And I have to say that all of you, GCAP has been such a wonderful collaborator. You've really made my first 2 months amazing in terms of the global energy, inspiring people at the People's Vaccine Alliance, but also in the United States and Europe, our allies that have been inspired by the work of colleagues all around the world, but especially in Africa. So thank you so much, Kabengo, for all of the energy in the last couple of months. As I've said, when I first joined this webinar, I apologize to Becky and Pradeep because my lovely slides with all of my graphics, just as I was transferring them to my desktop, disappeared. But I do have them somewhere, so I will find them and share them with all of the links and the graphics later. So for today, I will just be talking, which I hope is fine. And I would appreciate, Pradeep, if maybe when I have 2 minutes remaining, you could just kind of give me a wave so I can wrap up. That would be great. And interpreters, please let me know if I speak too quickly, which I know sometimes can be a problem. So, the first thing that I wanted to say was just remind people, Pradeep has already noted for us where we are in terms of vaccine inequity. We have some countries that are at over 90% vaccinated, including some of the countries in the global south, interestingly, like Chile is at 92% fully vaccinated, but then we still have countries in the global south, in Africa, in the Caribbean, in Asia/Middle East that are at 1%, Burundi still at 0.1%. We have Haiti, which is at 1% fully vaccinated. So always, that's something that I know the colleagues at GCAP don't need to be reminded of, but I know there are some people around the world that are not aware of that disparity. Also don't need to remind all of you of the global burden of this pandemic, the economic damage, the lives lost, the suffering, the fact that women have shouldered really the heaviest burden of this pandemic in terms of socio and economic impact. Something that comes back over and over about the cost of the pandemic is the lack of recognition of the deaths in the global south. So we're told that there's an average, that there's an estimated 6 million people who have died from COVID since the start of the pandemic. But what we know through recent modeling is that the numbers of deaths are actually much higher. So recent modeling has shown us that it's probably closer to 20 million people who have died of COVID. And that's something that we need to be, oops, sorry about that. My camera has just gone off. So that's something that we need to be aware of. Where we have vaccine inequity, we also have diagnostics inequity. We also have issues with registering deaths in a way that really counts every person with their cause of death. So what recent modeling has told us is that the deaths from COVID are probably closer to 20 million, so 3 times more than what we think. And also we are told a narrative of the deaths being greater in the global north. People remember that Italy, Spain, the United States were hit quite hard early on in the pandemic, And there's still a narrative that the deaths in those countries were higher or are higher than the deaths in Africa, for example. What we do know is that people in poorer nations are 1.3 times more likely to die as a result of COVID. And that's something that I know Kavengo is very passionate about, has spoken about at PVA Africa meetings, PVA meetings. How do we make sure that we tell the stories of the deaths in countries where people think, because the diagnostics are maybe not as good, that the deaths from COVID are not as high? Something else to keep in mind, and I know we'll talk about that with colleagues from around the world, is that there are also disparities within regions. So you have a region like Africa where some of the island nations are at very high vaccination rates, and other countries like Burundi, et cetera, that are at low vaccination rates. So we have that sort of disparity, but we also have disparity amongst people within countries. So we know that marginalized people, racial and ethnic minorities, are more likely to get COVID and more likely to die of COVID. I saw data that showed that Afro-Brazilians are 1.5 times more likely to die of COVID than other people in Brazil. So those types of disparities are also something that we need to keep in mind. As we have all been suffering the cost of this pandemic, 10 of the richest men in the world doubled their fortunes. So the 10 richest men in the world doubled their fortunes during the pandemic. And there have also been a whole bunch of new billionaires that have been minted, as they say. 40 of those new billionaires became billionaires through fortunes related to COVID-19. So vaccines, diagnostics, personal protective equipment, et cetera. So that's just something that we should keep in mind when we think about how we got here and the way out. So in terms of how we got here, there's been a lot of talk about how quickly the vaccines were developed. And that was really because of the huge financial investment, $100 billion invested in pharmaceutical companies from governments to make sure that the manufacturing and the development happened quickly, but also a real unprecedented collaboration between scientists and researchers from around the world. So that's part of the reason these vaccines were developed so quickly. And the reason I say that is now, as the CEO of Pfizer is giving his book tour and talking about how quickly Pfizer and he developed this vaccine, when he has been asked about vaccine inequity, about sharing IP rights, he says that that would stifle innovation, that a company like Pfizer or a company like Moderna invested so much in the development of these vaccines that they should not be punished by sharing IP rights. So that's why I think it's important to remind people of the amount of money that was invested in these companies to allow them to develop these vaccines. Something else about where we got here, because really, the way out that I want to highlight today is, the way out is really to waive patents and other intellectual property protections associated with these vaccines, and treatments and tests and other COVID technologies, so that countries can manufacture their own vaccines and products, or obtain access to lower cost products from other countries that can manufacture them. Something here that, maybe we can talk about a little bit in detail later if we have time, Becky. People often say, what about COVAX? COVAX would have worked in an ideal world. That was a pooling mechanism where countries joined, bought vaccines at low price, put them in a giant bucket where hopefully poor countries would not have to pay, and vaccines could be distributed equitably. That failed, for a few reasons. One of them is the fact that COVAX signed a very hefty contract with the Serum Institute in India. And during the second wave in India, the Serum Institute stopped exporting. But in addition, companies like Moderna and Pfizer did not put their vaccines into that pooling mechanism. They preferred to sell their vaccines to the highest bidder, and then the rich countries jumped the queue. So even though they said in theory they were protecting COVAX, they went directly to these companies and bought the vaccines at a higher price, and also hoarded vaccines. So you had a country like Canada that not only bought vaccines directly from the companies, but then bought 5 times more than it needed for its entire population. So that's something that comes up over and over as well. We have a mechanism, we have COVAX. COVAX has not worked in the world where we're dealing with pharmaceutical company greed and the nationalism of the rich countries that have set up and continue to support this situation. So now we get to the TRIPS waiver, which I know GCAP has worked a lot on in the last couple of months. The TRIPS waiver is a suspension of, so basically it means that the patent holders will not be able to legally seek or legally force patent or other IP rights during this temporary period. And this, as Pradeep has said, is an application that was put in to the World Trade Organization 2 years ago. Millions of people have died since October 2020, so a year and a half ago since this application was put in. And this has been blocked mainly because the rich countries, particularly the European Union and the UK, are not pushing this whole TRIPS waiver negotiation to the extent to allow us to get it to be passed. It's a temporary waiver which would allow during the pandemic for these IP rights to not be enforced. So Pradeep, you mentioned the recent leaked text of the so-called compromise, and I hope we'll be able to talk a little bit about that. But something that I wanted to, and I do have a map when I do share my slides that you can see the countries that support the TRIPS waiver and the countries that don't, but over 100 countries have supported it. Even the United States has supported it, even though initially their support was a bit weak. The trade representative recently did say some things that were a bit more encouraging about this compromise, that she said the US did not support this compromise language. But now, something important to point out is that South Africa and India are really in a difficult situation. They're being pressured to support this compromise language. And something that we have seen, and I know that those of you who received the emails from the People's Vaccine Alliance have seen these, civil society has really come to the table in terms of pushing back on this so-called compromise. One thing about the compromise, so-called compromise language that was, maybe slightly hopeful is the fact that the European Union for the first time admitted that intellectual property could be a barrier. For all these months, they were saying intellectual property is not a barrier, but finally they accepted that it was. However, the guidelines that they're putting in place, in this compromise deal are really, really weak. And MSF, Doctors Without Borders, actually had a very good analysis, which will be in the links that I share. But basically, and if you don't mind, Becky, I just want to read these out because I thought it was quite clear. The key limitations of the leaked text include that it covers only vaccines, so does not include treatments, diagnostics, the other necessary tools. So it covers only vaccines, is geographically limited, and covers only patents and does not address other intellectual property barriers, such as trade secrets, which may cover critical information needed to facilitate manufacturing. Regarding compulsory licensing for patents on COVID-19 vaccines, the leaked text introduces unnecessary reporting requirements for World Trade Organization members that could undermine the effectiveness of the mechanism. So really what they've done is given a very, very weak version of the TRIPS waiver, and that's what civil society is pushing back against. Some have said no deal is better than this deal. Something that comes up over and over is that Pfizer, Moderna, even somebody like Bill Gates has said that there are no manufacturers in the global south that can make these vaccines, even if the intellectual property was waived, even if the know-how was shared. That has been shown to be absolutely not true. It's actually quite colonial and, quite frankly, racist language to say that only white men sitting in Cambridge, Massachusetts, or in Oxford in the UK can make these vaccines. There have been studies that have shown that there are at least 100 manufacturers around the world that are ready to make these mRNA vaccines if they receive the recipes and the know-how and the intellectual property barriers are waived. Some of you may have heard of the mRNA hub in South Africa that's supported by the World Health Organization. They were able to produce, with no support from Moderna, something very similar to the Moderna vaccine. Since Moderna is not sharing any information with them, they actually now have to implement a clinical trial, which won't start until the end of this year, in order to do the tests of efficacy and safety on this new product. When asked about it, the CEO of Moderna, Stéphane Bancel, said, well, when you compare a fake Louis Vuitton bag to a real Louis Vuitton bag, do you think that they are the same? So to me, that just goes to show how offensive this person is, somebody who is now worth $6 billion. People are dying. His company refused to share information with this mRNA hub in South Africa. They were able to create a vaccine without Moderna's help. And he is speaking about Louis Vuitton bags. So to me, that just goes 2 minutes.
1 or 2 minutes.
Oh, conclude. I'm sorry, I didn't see you waving.
No,
okay.
1 or 2 minutes, no problem.
2 minutes. Okay. So that is just, and I'm actually close to the end. I have some steps about sort of how we move forward, but I know that today we wanted to focus on the TRIPS waiver. But that's really why 2 things is the fact that the pharmaceutical companies, with support of countries in the European Union, even the United States itself, to be honest, could do more to push a company like Moderna that has received so much money from the US government to develop this vaccine and has made billions of dollars recently. And in Latin America, we've seen this. Pfizer in the Dominican Republic for a treatment, for a compulsory licensing for Pfizer COVID treatment, objected to compulsory licensing in the Dominican Republic, saying that its human rights as Pfizer, the company that is worth $200 billion, its human rights were being violated by this proposal for a compulsory license. So you can see what we're dealing with. That's why, since the voluntary licensing didn't work and none of these companies have voluntarily shared their information, even with a hub supported by the World Health Organization, this is why we are pushing for a TRIPS waiver that will force them to waive those IP rights and also allow for sharing of know-how and tech transfer. In terms of a way forward, we need to make sure that the vaccine rollout is ramped up. We need to maximize production of safe and effective vaccines. And also there's a health system strengthening aspect and health financing that needs to happen. That's something that a lot of people are talking about now, even in countries where vaccines are available in the country, in the borders. More needs to be done to support the rest of the health system and to make sure that we address the concerns of the marginalized communities that I know Prof and the rest of the presenters will be talking about today. So I know that I ran through that very quickly. Once again, I apologize for not having my slides available, but when I do share them, you'll see the graphics and there are links to the MSF statement. There's a link to the actual TRIPS waiver application so you can see it and other documents that will hopefully be useful to you. So thank you so much, Becky.
Thank you so much, Maza. We learned a lot, no? And thank you for updating us on what has been happening, especially on the background of what is being, I just found it horrendous that mRNA vaccine know-how is now a luxury and a designer of a good officially. That's really strange. No, when 20 million have died, or at least officially, if 6 million people have died already. So thanks for your food for thought. Very important. Can we now go to Professor Gupta? Professor Gupta is going to speak on the topic of digital health, addressing the fragile health infrastructure in the world in the context of COVID-19. Professor Gupta is a leading public policy expert in India with vast experience in policy making. He has been involved in major global initiatives on digital health and holds several key positions in the digital health arena. He is a former advisor to the Union Health Minister, Government of India, and played a key role in drafting the National Health Policy and National Education Policy in 2020. He was nominated by the World Economic Forum on the Global Agenda Council for Digital Health and author of the book Digital Health, Truly Transformational. Professor Gupta, go ahead. You have the floor.
Thank you, Becky, and thank you, Pradeep, for inviting me. And Maza, always a pleasure hearing you. Laced with facts, I would say that if the number 20 million is right, it was not the death of 20 million, it was the death of humanity. When I look at those sordid stories of billionaires or rich people, I thank God neither I'm rich, neither I'm billionaire. I would never like to be one. With that having said, we all know that, that COVID did not, and I say that COVID did not break the healthcare system. It just exposed a broken healthcare system. Something that we have been silently talking about, but I think as one of my colleagues said, that the people who died left a living testimony of the broken healthcare system and of our, I would add, lack of consciousness too. I know my topic is role of technology, and we know then when the world was locked down and closed, it was only the technology and internet that kept us going and kept us connected, and probably also kept us doing our job. The world, I think, suffered a lot due to COVID, but it also kind of exposed on one side the broken system, but also brought forth such noble souls that we see on this screen today, who are not just passionate but are committed to the cause of saying, let's be frank and remove the inequities that are there in the system. So, all I see that proliferation of technology and the proliferation of vaccines both mirror each other. If you really look at it, they have a lot of similarities. As someone rightly put it, the future is already here, but it is unevenly distributed. I would also say that vaccines are in abundance, but they're garnered by the rich. They are also unevenly distributed. As I think Maza said, Canada has amassed 5 times the vaccines they need. So certainly there is no scarcity of vaccine. The scarcity lies in not being human enough to accept that others need it more once you have got your shots. So the rich and powerful have access, or rather first right on vaccine, and probably poor people, I think, are at their mercy, or it is actually driven by financial status, I must say, not by the health status. That's what I see. The people who go to work need vaccine more, but people who sit in the air conditioned cabins or cars are actually the first recipients or the claimants for the vaccine. How could digital health systems work? Now, this brings me to an area that I have done a lot of work probably in the last 25, 26 years. Digitalization is important for universalization of healthcare. There is no universal healthcare without digital health. Let me put it that way. Because what digitization does, it can convert coverage to usage. Today, you would not know how many people are vaccinated or how many need vaccination if you don't have their health data. So that brings you to the fundamental point of saying we need digital health. Also, as I mentioned in my book, that health has to be where people are. They are on the internet. So we need to take health to the digital medium, to the digital platforms. And also, one of the things that I would add is that today, internet is a social determinant of health. You like it or you not, but that's the reality today. If that's the reality, then digital health has to be an integral part of healthcare. Now, what we need to do, how do we use digital health? All through, I think I only track 6-7 decades, probably more when I look at to the colonial past of how health has been, shaped. We always had a 3-tiered system. You have the primary healthcare, you have the secondary healthcare, you have the tertiary healthcare. What we need to do today is make it 4-tiered. I think as People Vaccine Alliance, which I also think is a People Conscience Alliance, because we try to keep hitting people that, hey, look, you need to go back to your conscience to make decisions, at least about health. That make it 4-tiered. Let digital health be at the base. And when I say that, there are clear actionables that I would point here. Of course, there's a lot of things that I've written in the book, so I would not repeat here. If you have the digital health system, the first thing you have to see is the data. 60 to 80% of the needs of people in remote or rural areas is about basics of health. Right information, and the basic problems they suffer is diarrhea, fever, pain. These are basic things that can be solved by primary interventions or the OTC drugs. If you could give them digital consultations, 2 things will happen. They would not have to come to the district health facilities or the hubs, stop their earning and start their spending. Second thing, they would not take the precious time of the medical resources. In every country today, I think there's scarcity of medical resources. So the first thing I see is move to digital primary care as a first level of healthcare system. Start doing the health risk assessment. Health risk assessment does not require point of care diagnostic or invasive test. I could, from certain key statistics and my genetic parameters, could actually be identified if I am at a risk or predisposed to a disease. Check that, go for screening, If you need, go for diagnostic and probably preemptive care, not preventive care, preempt the occurrence of disease. So I think digital technologies and tools have a big role to play. The second important thing, which I think is very relevant in times of COVID, is the digital healthcare logistics system. And I'll give you an example. A few years back, I went to a remote health center in Karnataka, which is southern part of the country. And I went to a primary health center. So they had the vaccine. They did not have the syringe. And they said the challenge here starts because all the primary health centers were sent the same vaccine, but not the equivalent amount of syringes to support that. I asked him, so when will syringes come? He said, I have ordered. I can't use the vaccine till there are no syringes. If there was a digital logistics system, those who got the vaccine more than they needed based on the prediction, they could have reallocated. Syringes could have been ordered commensurate to the supplies of vaccine. So a digital logistics system is very important. As I talked about the health risk assessment tool, eventually what I see, I think this is, Maza, something that we should talk besides this vaccine alliance, is a global South-South collaboration. When I was advisor to the health minister, I said that we have tertiary care institutes in India like the AIIMS, Postgraduate Institute of Medical Education Research in Chandigarh, Lucknow, where we see 10,000 patients in the outdoor patient department every day. Just imagine if we convert their data and put algorithms and create a decision support system. Typically in LMIC countries, the population and the conditions would be kind of mirroring each other. We could create a great decision support tool. If we added that to the electronic health record, you may not require a doctor at the primary point of care, because the moment you start keying in Rajendra Pratap Gupta, age this, suffering from fever, this, you say, look, this is the first provincial diagnosis, this is the second, this is third. You could actually look at related, and you would actually get primary care delivered through technology. Countries like India and I think the global South, if you will look at, we could actually develop a decision support system and provide it free to the rural remote communities, which could be given to workers like ASHA workers in India. We have 1 million of them. Same way we could create allied health workers who could take care of the needs. That's one. I think World Vaccine Registry, today we have, as you said, Burundi is 0.1%. We could actually have live dashboards rather than looking at worldometer, which I don't know is how authentic, and look at what do we do with it. That is very, very important today. When we have a COVID app in India, where I think we have now close to 200 million plus downloads and users, entire population has been covered with that app in terms of registry, in terms of delivery of vaccine, even boosters may happen. We can do the same for tuberculosis.
If you can wind up in 2 minutes or something.
Yeah, I will. I have to leave for a UN meeting that's already in progress. I have to be doing that. So obesity or metabolic disorders are something that we got to look, because that's something we got to attack. Technology can help the divide in terms of inequity, planning, allocation, and even utilization, because that will convert coverage into usage. That is something we should aspire for healthcare system. As I said last time, vaccine inequity is directly proportional to economic inequity, and economic inequity is directly proportional to the levels of conscience which you probably don't have. I think with that I will end, and I am thankful to all of you for enlightening me on the aspects that I heard, Maza, and I hope I could have stayed back, but I will listen to the entire talk, once you send me the link, and let's work together to reduce the inequities. I thank you so much.
Thank you so much, Professor Gupta. That's very enlightening. I like the idea of putting up a fourth tier into the health systems of countries, especially those that are poorest, no? Because it's very important to be able to diagnose at early stages using technology. And I guess one thing that came into my mind as well is the role of local governments in these digital platforms. Very important. No? So thanks for your presentation. I'd like to now go to our next speaker. Our next speaker is Mr. Mishra.
Yes.
Yes. Okay. Mr. Mishra is a former Supreme Court advisor on the right to food in India. He is a key member of the Right to Food campaign in India, and his organization called Rupayaan is currently engaged in vaccinating people in the remote hilly areas of Odisha in the eastern province of India. So he's going to share with us the experience on the last mile vaccination in Odisha. You have the floor, Mr. Mishra. Go ahead.
Yes, thank you. Thank you. First of all, thank you, Pradeep, for inviting me to share our first-hand experience. I am right now in a state called Chhattisgarh, and I have really walked down around 7 kilometers just to get the internet. But unfortunately, I don't think if I'll switch on my video, that will not support. So sorry for that. But I am really thankful to Maja, also Professor Gupta, for setting the context, international, also national context. But as you have already mentioned, that we are in the field ensuring last mile vaccination in one among the eastern states of India. So I'll stick to four, 5 points based on experience. That is, Government of India committed that they will vaccinate everyone free of cost. Despite that, they are also providing vaccine to private hospital where people with paying capacity, they can go and vaccinate themselves. But most of people, they more are relying on government supplied vaccination, because as I have interacted with many middle class or upper middle class friends, they are of the opinion that the cold chain management of government is far superior than private hospitals. So they are relying mostly on government supplied vaccines than going to private hospitals and paying and vaccinating themselves. That is one. Then I am also thankful to organizations like Azim Premji Philanthropic Initiative. They are actually supporting many smaller organizations working in remote tribal areas, just to ensure that the commitment of Government of India is ensured, and by helping the health machinery to see that the last man in the village is vaccinated. So based on 4 months experience, these are 4, 5 points which I would like to highlight here. One, government in itself, I don't think they have the capacity to reach to the remote, hard to reach villages, especially where tribals are living, unfortunately, coincidentally. So as a civil society organization fighting at the global level or at the national level, just to ensure that everyone is vaccinated. Similarly, there are smaller organizations like us who are ensuring vaccinating people, those who are living in margins. So for doing this is not a very simple thing. So you have to coordinate. First thing, you have to coordinate with the health system locally. For many friends, that is not a very easy task, because you are encroaching on certain area. They feel like that. So coordinating with that one. And what we have witnessed, that earlier government were managing static CVC, that is COVID vaccination centers, where they were expecting that people will come and vaccinate themselves and go back to their houses. But that is not the case. As you all know, that this is not a health emergency, but it has got tremendous impact on social, also economic impact on poor. So when people are getting opportunity for their own earning, managing families, so they are preferring go to work than to go to any CVC and vaccinate themselves. In this case, what we did, we brought CVC to the villages. So nowadays, every week we are declaring that on this village at this particular time our vaccination team will be there. So that is one. And how we are doing it? Like we are supporting government with more human resources, like nurses, also a person who will update that one in the CoWIN app or portal. So 2 people are going to every village just to ensure that first and second 100% vaccination of both first and second doses, also booster doses. That is one. Line listing is most important. So we have to list out everyone in those areas, so that you can see whether they have vaccinated or not. If not, then you have to approach them personally or over phone and all that. There is also, as Professor Gupta have already highlighted, there is digital discrimination. Like you will find many people, those who don't have mobile or cell phone, or even they don't have Aadhaar card. So how you are going to manage those people? And most of them are poorest of poor. So that is also a challenge. For that, there are also Government of India has made some changes in the CoWIN portal or CoWIN app, so that people having no Aadhaar card or mobile or cell phone can also get vaccine. The other part is there are a few people who cannot move out. So you have to ensure that you are going to their doorstep and vaccinate them, either for some reason or other. Mostly due to morbidity or illness, they cannot move, or due to age factor, they cannot go out. So this is also a challenge which the facilitating NGO, those who are ensuring 100% vaccination in India, are facing. The other part is supply chain management. So in last 4 months, fortunately, we have only 3 days where we found that vaccine is not available in the health center. So we have to stop vaccination in for 3 days in last 4 months. So the supply chain management is also an issue. These are all things which actually one has to see that last person in the village is vaccinated. So I am in Chhattisgarh, where actually right now I have gone for some meeting, but what I witnessed in that village, no one is around. All were in the jungle just to collect mahua flower. This is the season, and this is which they cannot leave it behind. So we have to wait for people just to, in case of vaccination also, we have to adjust as per availability of people in the villages. So these are a few points which I think civil society organization, those who are working in the field, struggling to ensure that last man in the village are vaccinated. So thank you, Pradeep, once again. Thank you, Maja. Thank you, Professor Gupta, and everyone for giving me this opportunity to share our experience with you all. Thank you.
Thank you very much, Raj Kishore. Sorry.
Yes,
Yeah, thank you very much. It's very important really to reach the poorest of the poor and those geographically isolated areas. No? In the Philippines, we have the same issues. We have the same problems because the most marginalized are not yet vaccinated. And mostly, obviously, these are in the rural areas and in the hinterlands. But and sharing your insights on what you are doing really gives impetus for all of us as activists to really work harder, no, in terms of reaching them. So at this point, we will have a short question and answer for the first panel. So if there are any questions for the speakers, you can ask them now. Any questions? Anybody who wants to speak, please speak up. Please raise your hand if you want to ask questions. Aristide? Aristide, are you asking a question? Okay. If there are no questions, okay, Maza, your hand is raised. Please go ahead.
Yes, thank you. I would like to a question of Mr. Mishra, Kavengo and I are in a group together at the People's Vaccine Alliance where we work to try and amplify stories from around the world of these, stories of marginalized people who are really at that last mile, as he says. And I just wanted to know, Mr. Mishra, if they were individual stories that you would be, and we can definitely follow up about this offline, but this is something, and I wonder if people agree, often there's a lack of understanding of the reality on the ground. Just the fact that, you had to travel 7 kilometers just to attend, to participate in this webinar is something that for most people who sit in webinars all day, they would find really above and beyond the call of duty. So just in terms of being able to access stories, of a certain individual who has had to do the same kind of trip just to be able to try and access their vaccine. Is that something that you think you would be able to share with GCAP colleagues and maybe myself at the PVA so we could try to amplify?
Yes, sure, no issue. I'm already in touch with Pradeep. He's a good friend of mine. So I've also shared some photographs. I hope Pradeep have used that. So no issue, we can share it.
Thank you very much.
Thank you very much, Mr. Mishra. Abdul Awal, go ahead, Abdul Awal.
Thank you, Becky, and thanks to Maja, Raj Kishore Mishra, and the speakers. All of the really very important issues the vaccine equality campaigners raised. In Bangladesh, we are a little bit advanced situation, but in exchange of big debt, Bangladesh already spent 2.3 billion. I'm just adding some points, not asking anybody to acquire the COVID vaccines. And since till now, Bangladesh reached the target, even more than that, already 27.22% received first dose and 67.19% second dose, and 8.9% of the population has received. But the issue is the equity of access to the vaccine distribution system. Like any other countries, most marginalized are still left behind, especially in remote areas, in ethnic communities, in the tribal areas, and the poorest people. And the main barrier Bangladesh identified in the civil society is the patent right. Some corporates tried to establish, to produce the vaccine if the patent right waiver happened. And Bangladesh took a very positive step at global level to raise this issue of patent right waiver issues temporarily for the vaccine and for the medical instruments for using this, for addressing this COVID-19 crisis. I'm just concluding here that as a campaigner, the civil society organizations are raising this, and some southern countries like Bangladesh raise this in the global arena. But till this, as Maze was raising this about a kind of superiority that the South don't have the capacity, but 2 companies, at least in Bangladesh, have tried to produce the AstraZeneca. And when the India was also unable to supply due to the crisis in India, and they could not address their commitment of supplying the AstraZeneca vaccine to Bangladesh. But however, the country like Bangladesh really achieving something, and the civil society is very much aware and raising this issue, but still the trip waiver issue for the vaccine production and also medical instruments, because I think one point came here about the broken healthcare system in the southern part of the world, even in the whole world. It exposed the inequalities and expose the weaknesses of the healthcare system. So this is also the root cause, one cause of the inequality of having access to the treatment. So the vaccine inequality and inequality of having access to the healthcare system should jointly be raised by the campaigners all over the world. And also we should give emphasis on the patent right waiver issue. Thank you very much, Becky, for giving me space.
Thank you. Thank you, Abdul. Good to see you. Georgina. Georgina, ¿tiene pregunta? ¿Cómo estás?
Hola, un saludo, Becky, Pradit, colegas que participan el día de hoy. Quería referirme a cómo poner en práctica la cooperación sur-sur que mencionaba el doctor a través de los procesos de vacunación, porque realmente la pandemia vino a desnudar la fragilidad de los sistemas sanitarios en el mundo y puso nuevamente en crisis el sistema actual. Por eso otro mundo es necesario y otro mundo es posible. Desde esa perspectiva, me parece que es interesante reconocer el trabajo que ha hecho Cuba en la elaboración, y esto lo digo por Masa, que hizo la pregunta, porque Cuba ha producido cantidad de vacunas y amerita tener un lugar y está intercambiando también entre los países del mundo. El otro elemento es que tanto México como Argentina están creando una estrategia para producir vacunas y ya la pusieron en práctica. Entonces, capacidad hay en el sur. Ejemplo de esto, estaba citando los países anteriores. El problema es que nos enfrentamos a monopolios que tienen las farmacéuticas y los laboratorios. Y desde ese punto de vista, este llamado que estamos haciendo, creo que es necesario involucrar a más organizaciones, a más movimientos, para que estas vacunas realmente lleguen a estos grupos que están siendo excluidos. Gracias, Bertie.
De nada. We have our last questioner. Well, I think she or he put down her hand. Okay, so we go to thank you very much to those who have raised questions and issues from their respective perspectives, and we'd like now to get to the next session, which will be focusing on the regions. We'd like to first invite the vaccine situation in Asia and our intervention. Zia Rehman from Pakistan Development Alliance. He is a former GCAP Council member. I have known him quite well. We work together. Zia is a social and human rights activist since he was very young. And he was the founder of Awaz, Pakistan in 1995. He's actually a mathematician, and he turned into a social activist. And he's a former Global Council member of GCAP. So may I invite Zia? Zia, go ahead.
Thank you very much, Becky, and thank you very much indeed GCAP for organizing this very important webinar on the issue of vaccine. Asia is actually the home of almost 2/3 population of the world. And we see that most of the population in Asia face quite difficult and different overlapping vulnerabilities. They are vulnerable because of climate changes, particularly the population that lives in South Asian countries. They are vulnerable because of the poverty. They are vulnerable because of income inequality. They are vulnerable because of rising extremism in the region. They are vulnerable because of the gender inequality. And because of this COVID-19, now they are vulnerable because of this vaccine inequality. We have seen that the high-income countries in the world more than 70 to 80% population is already vaccinated. Whereas in the low-income countries, and most of them are in Asia and Africa, we see that almost 11% population is vaccinated. Vaccination figures shared by the Bloomberg says that in Pakistan, 114 doses are used by 100%. In India, 130 doses are used by 100 persons. In Bangladesh, 154 doses by 100 persons. Whereas we see that the largest number of doses being used by 100 persons were in Cambodia, in the region, and the lowest one were in Afghanistan, where 17 doses were used by 100%. So you can see the inequality, the rising inequality among distribution of vaccines in this region. And we have been reported that the Western countries are also engaged in hoarding of vaccines like pharma companies. So if the countries, Western countries, are hoarding these very important vaccines, which are much more beyond the use of their own population, why they are not distributing among the poor in this region? In Bangladesh, the indigenous people cannot access vaccination because they do not have internet to register themselves to avail the same. In Pakistan, interestingly, only 37% women are vaccinated out of the 50% population, which is totally vaccinated. And the reason is that almost 12 million women in Pakistan do not have their computerized national identity cards. So because they do not have computerized national identity cards, therefore they cannot register themselves in the digital system, which was introduced by the NCOC, and therefore they are unable to. And as I've said, that in Bangladesh, the accessibility of the internet facility to the poor community is one of the major impediments towards the vaccination, availability of vaccination to the poor. In India, Dalits have been facing discrimination in getting access to the vaccination. In Nepal, there are issues of rural and urban divide, and particularly the issue of in fact, procurements and shipments and maintenance of cold chain is somehow very much there. Overall, GCAP Asia has been engaged in the issue of vaccine inequality since the beginning of March, February 2020. We have mobilized masses across Asia, where we are present in several countries. The national coalitions, the members of GCAP Asia are actually trying to mobilize the masses and sensitizing them to get access to the vaccinations. This is one activity that we actually did. Alongside that, we also wrote letters to the European countries allowing, permitting for the TRIPS waiver. And in Nepal, Japan, India, we host Pakistan Vaccine Alliance process already. We are part of the People Vaccine Alliance Asia, and our regional coordinator, Pradeep, has been actually steering the committee as a committee member. We are doing webinars on this TRIPS waiver issues, mobilizing the support for from the masses and the government and the agencies. We carried out Twitter storms. We discussed these issues at the national people assemblies and regional SDG forums, particularly in the recently Asia Pacific Forum for Sustainable Development held in the region, and we highlighted these issues over there also. So in Asia, in fact, one of the major issue is that because of these vaccine inequalities, people have been doubly suffering from, and they are facing many other, overlapping vulnerabilities, as I've shared earlier. And the demand is that in order to reach out to the people for the vaccine, in fact, we need to facilitate the governments in Asia, in fact, to develop that kind of system. Whereas the major issue is to sensitize masses, because people themselves are not actually much aware about the effectiveness and the use of the vaccine, particularly in the far-flung areas where in fact the information is not reaching. So there is a dire need to initiate and to sensitize masses at a wider level, to engage them, particularly for the vaccine facility, particularly to reach to them with this facility. Thank you very much indeed. I will stop here and I would look forward for the questions.
Okay, thank you very much, Zia. Before I go to the next part of our discussion, I'd like to acknowledge Aristide. Aristide, I'm very sorry to have missed you in the first part of the discussion. I mean, in the question and answer portion, but I see that you are again out of my view. Aristide, do you want to ask your question now? You see, Aristide has been raising his hand, but I could not see him on my screen, no? And now he's gone from view again. Aristide. Okay. We seem to have a very bad connection for him. Okay. We will go to your question after the presentation of the next presenter. Aristide, do you want to speak now? Okay. This is real world.
Oui, je suis en ligne.
Okay. I'm sorry. Well. Oh. Yes.
Oui,
j'avais
une préoccupation. Oui, j'avais une préoccupation. La préoccupation que j'ai, c'est effectivement les inégalités entre les réalités des nations. Parce qu'on a focalisé l'attention effectivement dans des grands centres sans tenir compte des habitants ruraux ou dans ces milieux ruraux où le numérique est encore chimérique, où l'Internet est encore chimérique, et où même pas la quantité de vaccins n'est pas encore disponible. C'est pourquoi je voulais poser la question, mais aussi une suggestion. Qu'est-ce qu'on doit faire pour qu'on tienne compte de tout le monde, non seulement des centres urbains, mais aussi des populations qui sont à l'intérieur et qui n'ont jamais eu l'accès à l'Internet, qui n'ont jamais eu l'accès au numérique, mais qui doivent également vivre et qui ont aussi droit à la vie. Qu'est-ce que vraiment, dans cette réflexion, on peut faire pour que tout le monde puisse en bénéficier, notamment et principalement les habitants des milieux ruraux. Merci.
Any of the speakers who want to address the question?
In fact, Becky, if I can just respond.
Yeah. Yes, please, Zia.
In fact, in rural areas, the issue is that there is a lack of infrastructure. The health infrastructure is not available in most of the rural areas in Asian countries. That is why the people do not have that access. One. The second is that, as I've said earlier, that there is a need of mass sensitization towards the acceptance of vaccination. Particularly if I talk about Pakistan, people, in fact, confuse vaccination with religion. And they say that this may be another kind of family planning, because in Pakistan, the people are much fond of having more children. So they are much concerned about and confusing this vaccination with the family planning and contraception. So this is quite unfortunate. I think this mass sensitization, particularly for the rural population, is also very, very important. And if they are sensitized enough, I hope that they may be able to get access to the vaccinations wherever it is available.
Okay, thank you. Maza?
Thank you, Becky, and thank you, Aristide. I think your question is really, at the heart of what we are trying to address here today. And I know that our colleague from India, who had to walk the 7 kilometers or travel the 7 kilometers to access the internet to come to this webinar, also is really in line with you and your concerns. So that's really, trying to reach groups that have not been reached and have been forgotten by not just COVID-19 response, but other health responses as well, I think is really what GCAP, I believe, is your work is based on. I see Becky nodding, but also what we at the People's Vaccine Alliance are really trying to do in this phase of the work. One thing that I would also like to say, and I know, Zia, I agree with you that there are always some people who will have questions or maybe have been misinformed or heard something that is not true. But I always have a hesitation when people speak about hesitancy when you have to walk 5 kilometers to access your vaccine. Because to be honest, I would also be hesitant if you told me that I had to leave my crops or leave my job or, and spend the 5 hours, and then maybe you even get there and they say, oh no, come back tomorrow. And then that you have to do the whole thing over again. So I think we really have to work very hard to be creative and to hold governments, local governments, national governments to account. We know how to do vaccination programs. I think, with children, it is difficult. It is different than with adults, but we know how to do this. We need to make an effort, and we need to make sure we know, and I heard somebody else say this earlier today, this is not our last pandemic, so all the work that we're doing now should support us for the next pandemic as well. So Aristide, I hope that answers your question. I don't think we will solve the problem today, but that's really the reason why we do the work that we do, to make sure that the most marginalized have access to the services that they deserve.
Okay, thank you very much. Next in our program, we'll talk about this vaccination situation in Latin America and the Caribbean. We have Sofia Montenegro Mejia from the PVA. Sylvia is a Guatemalan political scientist who specializes in public opinion and political behavior from the University of Essex. She has worked in organizations dedicated to evidence-based policies for the eradication of poverty, violence, and corruption. Sofia, you have the floor.
Muchas gracias, Becky. No sé si voy a hablar un poco en español y voy a intentar hablar despacio para también facilitar la traducción. Agradezco mucho a GCAP por la invitación y el espacio para contarles un poco el panorama de América Latina. Y quizás me gustaría empezar por contar la importancia que ha tenido el hecho de que en América Latina tenemos casi el 8% de la población mundial, pero hemos tenido el 30% de las muertes y fallecidos por COVID-19. Este exceso, esta dificultad también se ha reflejado en las proyecciones que ha tenido, por ejemplo, The Economist e incluso proyecciones de Lancet, donde se ha estudiado, como bien ya se han comentado acá, lo que ha sido el exceso de mortalidad y las posibilidades de que incluso las cifras oficiales no estén reflejando lo que está pasando en cada uno de los países. De hecho, en estas dos proyecciones, tanto de Lancet y de Economist, se suele decir que América Latina es una de las regiones más golpeadas y ha tenido pues la mayor cantidad de personas fallecidas. En ese sentido, nuestra región, pues como bien decía Maza y también lo han mencionado antes en las intervenciones, tenemos altas disparidades, desigualdades a causa del proceso de vacunación. Y los procesos de vacunación, en ese sentido, pues hay casos exitosos como ha sido Chile, que tiene más del 90% de su población inmunizada, pero luego tenemos casos en Centroamérica, en el caso de Guatemala, que todavía no supera o apenas supera el 40% de su población inmunizada. También tenemos casos, por ejemplo, como en el Caribe, en Haití, donde la población inmunizada tan solo llega al 1% del total que ha completado el esquema completo. Y bueno, esas disparidades creo que nos demuestran cómo los países más grandes, con economías y mercados un poco más grandes en extensión, pero también con mayor capacidad en sus sistemas de salud, como es el caso de Chile, tuvieron una ventaja cuando comparamos con mercados más pequeños y sobre todo con poblaciones que no tuvieron esa misma facilidad para hacer negociaciones con las corporaciones farmacéuticas. Esta desigualdad de las condiciones y de las capacidades de negociación son un poco lo que hemos hablado sobre la falta de oportunidades que se tienen y de cooperación que tenemos muchos de los países pequeños y los países que tienen desafíos más grandes para poder proveer sistemas y servicios de salud a las diferentes poblaciones. Incluso podemos hablar como en varios países, y creo que Georgina lo habló, ¿verdad? Tenemos una excepción bastante grande, que es el caso de Cuba, donde la vacuna soberana ha tenido, a diferencia de otros países pequeños, la capacidad de poder generar, producir y aplicar las vacunas al resto de su población. Quizás ahí, en el caso de Cuba, valdría la pena señalar que no ha tenido la capacidad para poder exportar esta vacuna debido también a las condiciones políticas y, de hecho, las relaciones de embargo que todavía se mantienen en relación a sus relaciones diplomáticas con Estados Unidos y con la región. Y esta falta de solidaridad, que también se platicó antes, es algo que también deberíamos de discutir en esta ocasión, porque es precisamente lo que dificulta lo que podría ser una cooperación de sur a sur. Y también dentro de las regiones que vemos que tienen diferentes condiciones, donde podríamos aprovechar la producción para poder realizar mejores condiciones. Y una de las cosas que también creo que es importante y volver a rescatar es quiénes han sido los más afectados de esta pandemia. Vemos, por ejemplo, cuando ya examinamos un poco lo que comentaban de la situación de Pakistán, también sucede en Guatemala, por ejemplo, que vemos que existe una gran barrera en relación a quienes van a poder tener acceso a las vacunas. Cuando vemos la población indígena, por ejemplo, en el caso de Guatemala, ha sido de las menos priorizadas en los planes nacionales de vacunación. Solo para darles un dato muy pequeño, tenemos una relación casi del 70% de la población ladina que ha sido vacunada en el país, en Guatemala, mientras que tan solo el 18% de poblaciones indígenas han sido vacunadas. Y esa diferencia entre ladinos e indígenas también es algo que se puede percibir en países como Bolivia, que también tienen población indígena, en Perú también, Y es algo que también se repite cuando vemos la distribución de las vacunas en poblaciones urbanas y en poblaciones rurales. Donde en Honduras, por ejemplo, también más de la mitad de las personas que han sido vacunadas han sido personas que habitan en áreas urbanas. Y en el caso de otros países, y como bien lo mencionaba Georgina, pues también estamos ante una situación en la que personas en condiciones de vulnerabilidad, como por ejemplo migrantes, en el caso de México, no se han priorizado y no han recibido atención de parte de las autoridades de gobierno para poder facilitar estos procesos, ya que como no son personas que aparezcan en el registro público, no pueden obtener o tener acceso a las vacunas. Y esto también sucede en algunos países con población migrante importante, como es Colombia, donde tenemos el éxodo y la migración de población venezolana al país, y lo que también nos dificulta mucho el facilitar a estas poblaciones el acceso. Algo que mencionaba Maza y también me gustaría rescatar es que las diferencias incluso étnicas, incluso basadas en la raza de las personas, como en el caso de Brasil, ha ocasionado que exista también una probabilidad más grande de las comunidades afrodescendientes de poder fallecer a causa del COVID. Y esta población ha sido también la menos priorizada para el proceso de vacunación. Entonces, quienes están siendo más afectados, para resumirlo, han sido las comunidades que, debido a sus características, tienen una serie de condiciones que les imposibilita el tener acceso rápido, equitativo y una distribución más justa de las vacunas. Y eso para no mencionar, porque no sé cuánto tiempo tengo para mi intervención, lo que viene siendo los tratamientos para el COVID, que incluso pues esto vale la pena porque en América Latina sabemos de que hemos sido excluidos del fondo para medicamentos que podría servir para poder tratar y aliviar lo que va a ser la posibilidad de tratar lo que es el COVID e incluso pues tener acceso justo en los precios, en el acceso rápido que podamos obtener medicamentos como por ejemplo Paxlovid. Ya sabemos que tenemos varios países en América Latina que han sido excluidos de esta negociación con la farmacéutica Pfizer. Y bueno, también un desafío que sigue y permanece en la región es la cantidad de pruebas que se pueden realizar para poder dimensionar cómo ha sido la evolución de la pandemia. Con la variante Omicron, lo que detectamos es de que si bien pues al inicio se prestaba mucha atención para poder determinar el efecto que estaba teniendo en países, posteriormente los países empezaron a reducir la cantidad de pruebas que estaban realizando en América Latina, y esto nos lleva a una situación donde no sabemos el estado real de cuál es la cantidad de personas que han sido contagiadas y cómo se mantiene la evolución de la pandemia. También algo que ha cambiado con el tiempo es que estamos ahorita teniendo información sobre cuáles fueron los precios que se realizaron de las negociaciones con las diferentes farmacéuticas. Estas investigaciones al inicio pues no contábamos porque se tenían cláusulas de confidencialidad con las diferentes farmacéuticas, en las que muchas farmacéuticas establecieron sus propios precios y realizaron como el volumen de cantidad de vacunas que se iban a implementar y adquirir. Y de hecho existen ahorita pues ya casos que se están auditando, como es el caso de la vacuna Covaxin en Brasil, donde el presidente Jair Bolsonaro pues está haciendo auditado por la fiscalía porque se negoció una vacuna que estaba sobrevaluada por el precio. Este tipo de investigaciones esperamos que se vayan a empezar pues a difundir y que nos revelan estas negociaciones injustas que tenemos a raíz de los privilegios que tienen las corporaciones farmacéuticas. Y bueno, este es un poco el panorama que me gustaría reflejar y también lanzar un poco la pregunta que decía Georgina y rescatar un poco de esta conversación. ¿Cómo podemos desde el sur global pues afianzar lo que podría ser una colaboración efectiva para poder priorizar a las poblaciones vulnerables que han sido las más afectadas y garantizar que pues en futuras negociaciones no se den este tipo de privilegios y falta de transparencia en los procesos donde los que más perdemos pues somos todas y todos que estamos sujetos a servicios y el bienestar de nuestros sistemas de salud pública.
Thank you, Sofia. Muchas gracias. Okay, our next speaker, I'd like to know, is Georgina speaking?
Sí.
Georgina, sí, okay. You have 5 minutes, Georgina. Georgina is the co-president of Latindad. She's based in Nicaragua.
Okay.
Her interest and focus is on the social, political impact and economic justice issues on public policies. She's currently one of the co-chairs of GCAP. Bienvenida, mi amiga. ¿Cómo estás?
Hola, Becky. Hola, de nuevo. Voy a tratar de ir despacio por la traducción. Tal como lo decía Sofía o Silvia Sofía, yo quisiera compartir con ustedes que el 63% de las personas en América Latina y el Caribe ya han sido vacunadas contra la COVID-19, según los datos, ¿verdad?, oficiales de la OPS, pero esta cobertura para nosotros sigue siendo desigual, porque mientras 14 países y territorios han vacunado el 70%, prácticamente esa misma población o ese mismo número no se ha logrado alcanzar ni el 40% de cobertura. Y cuando hablamos de cobertura nos referimos a que no se tiene completo el esquema de vacunación según las dosis establecidas para una vacuna. Entonces eso es preocupante, porque esto está vinculado directamente a que no todos los países reportan el 100% de toda la información y resultados obtenidos respecto a la vacunación masiva, porque normalmente siempre este tipo de estudios o de datos tienen sesgos. Nosotros consideramos de que los países deben de proporcionar datos que muestren la cobertura de vacunación por edad, por sexo, por grupo de riesgo, porque estos datos son muy importantes para poder diseñar campañas de vacunación específicas que realmente puedan maximizar el impacto que se tiene, y consideramos también que los gobiernos deben de reorientar sus esfuerzos hacia las personas que tienen enfermedades crónicas, personas que tienen VIH, SIDA, adultos mayores. Por ejemplo, en el caso del Caribe, tenemos millones de adultos mayores que no han sido vacunados en Latinoamérica. Esto tiene que ver con una serie de concepciones que se tienen también con la cultura misma de los pueblos, pero también tiene que ver cómo hacemos un proceso de divulgación, todos los actores involucrados en este proceso. Y consideramos también que a medida que se implementen los planes de vacunación, es fundamental asegurar que condiciones como la raza o la discapacidad no sean obstáculos a la inmunización. Debemos demandar cobertura de vacunación por raza, etnicidad, residencia geográfica, edad, género y nivel de educación, porque realmente esas son grandes desigualdades en nuestra región. Y creo que también esto sucede en Asia, en África. Por lo tanto, tenemos que abordar la equidad de manera sistémica para asegurar que poblaciones vulnerables no se queden atrás con los lemas que se están usando. Las vacunas deben de ser accesibles a todo público, sin que haya obstáculos de índole religioso, político, cultural, social e inclusive genética, ya que lamentablemente las vacunas para prevenir diferentes enfermedades han causado la muerte de muchas personas. Y eso también tiene que ver con las deficiencias que presentan los laboratorios y las empresas que están a cargo de estos procesos. Prácticamente han pasado 2 años desde el comienzo de la pandemia y el virus se llevó más de 2.6 millones de vidas en Latinoamérica. Y encontramos amplias desigualdades en el acceso a la información oportuna y transparente. Por lo anterior, pues consideramos de que es necesario retomar algunas experiencias, como es el caso, bueno, yo voy a citar Nicaragua, que tiene una experiencia valiosa en la vacunación de la visita casa a casa. Eso es muy importante retomarlo en los países. El Ministerio de Salud ha dispuesto su personal hacia las comunidades más lejanas, hacia los municipios donde no hay accesibilidad. Por ejemplo, nos preguntamos cómo Brasil, Perú, cubren la zona de la Amazonía, donde está una cantidad de indígenas que están quedando sin vacunarse. Ok. Hola. Hola. No escucho. Hola, ¿me escuchan? ¿Me escuchan? Hola.
Yes, yes. I'm asking Georgina to wind up.
Ok, voy a cerrar ahora. Entonces, a pesar de la vacunación, en diciembre de este año, en la región se anunció un aumento del 18.4% en los casos de COVID. Y se cree que esto está motivado por la propagación de las variantes Delta y Omicron. Sin embargo, esto nuevamente nos demuestra que debemos de tener un lema: el derecho humano a la salud es fundamental. El derecho a la vacuna universal ante el COVID debe continuar siendo una bandera de lucha de nuestros pueblos. La exclusión de las comunidades marginadas en el proceso de vacunación se manifiesta en desigualdades territoriales, de etnias, de razas, de género, de estrato social, de las organizaciones de sociedad civil, sectores y movimientos sociales. Realmente debemos de tener como prioridad la demanda de vacunación para las comunidades marginadas y vulnerables, incluyendo migrantes, incluyendo la diversidad sexual, las personas con discapacidad y adultos mayores, y poner estos temas en los diferentes niveles de toma de decisiones en los espacios nacionales, regionales y globales. Gracias, Pradip.
Thank you very much, Georgina. I'm very sorry that we have extended our time. So I'd like to ask the next speakers. I missed Kavengo in the earlier part. I'd like to ask Kavengo from Kenya, and currently working as Africa coordinator of GCAP, to make a presentation of the vaccine situation in Africa. Kavengo, you have the floor. You have 5 minutes.
Becky, sorry, I think we're running out of time. Can we extend it? And requesting next presenters to limit it 4 minutes. I'm so sorry. Becky, is that all right?
Yeah.
Sorry,
Yeah, I just asked Kavengo to limit his presentation to 5 minutes and Kavengo, go ahead. You have the floor.
Kavengo, you are muted.
Okay, thank you very much, Becky, for that introduction and also for the time. I don't think I have so much to say, but I can just update you slightly that everybody knows by now that Africa is the least vaccinated continent in the world today. That out of the populations, 1.3 billion people, only about 143 million are fully vaccinated so far. So it remains the least vaccinated population. But within that total figure, there is also another story that there are countries that are doing very well and have reached and even surpassed 50% in vaccination, full vaccination of their population, like Botswana, Cape Verde, Mauritius, Rwanda, and Seychelles have achieved very high vaccination rates. And these countries seem to have something interesting in common. They are relatively smaller in population, also politically a little bit stable compared to others, and also relatively better health systems and better transport communication infrastructure, and then they are very well coordinated in terms of vaccination process for COVID. And their people also have a good level of awareness on the COVID. On the other side of things, the flip side, we have countries that are doing extremely badly, like have only less than 1% of their population vaccinated to date. Those include Burundi, Chad, and DRC, for example. And if you look at these countries, they are a bit or relatively unstable politically. That is, they have experience of armed conflicts. They have very poor infrastructure. Transport communications is very poor in many countries, and you've heard what Aristide has just said. They also have very poor health systems, and they have quite a number of governance challenges. And then they also don't have the vaccine itself to vaccinate their people, and the level of awareness of their people is also low, relatively low. So there are challenges related to this situation in Africa. One is that 99% of the vaccine, all forms of vaccine in Africa are imported. That includes the COVID vaccine itself. And then the vaccine unavailability is a big challenge in Africa. And then there is access issues. And I think somebody talked about, was it Kishore, who talked from Pakistan, about 7 kilometers. If somebody like Aristide were to talk, he'll tell you to reach a vaccination center is a journey, a big journey, possibly covering a day, not just 7 kilometers that's a very short distance. And therefore there are hidden costs to go for vaccination. And African families, in average, you have five people. And I talked to Aristide, he told me you need at least $20 to make a journey, an individual, to and from a vaccination center. That's an individual. How about a family? These are hidden costs that we are not talking about. Now, all these things, challenges put together are what the world is calling hesitancy. Conflicts are also hesitancy. Lack of systems are hesitant. All these are put together as hesitancy, and I think this should stop. So what we are saying is that there should be, a better, system of, producing the vaccine, which is what everybody has been calling waiving the trips. And then also improving the community awareness and holding African governments accountable in terms of distributing fair distribution of the vaccine to their people in rural places and urban places and minorities, as is the case or has been mentioned in South America. Let me stop there. Thank you.
Thank you very much, Kavengo. I think in most countries, it's the government that has the hesitancy. It's the government that doesn't want to deliver it. They're too lazy. Yeah? They're the ones who are hesitant. So let's go now to GCAP Greece, Marianela Cloca. At a very early stage, Marianela joined the humanist movement and dedicated herself to health, education, and advocacy missions in Greece, Africa, and Asia. She worked as a general manager for the Hellenic Association of PLHIV, Positive Voice, and supported the first steps of the Hellenic Liver Association and the Hellenic Drug Users Union. Since 2013, she has been working as the advocacy officer in Greek Praxis. She leads the campaign Praxis Access on Affordable Medicines. Marianela, you have the floor.
Thank you, Becky. Hello, friends. So now the European perspective. I've heard so many things concerning what is happening in the rich countries. So even though I don't consider myself a rich person, I would like to tell you what is happening here. So first of all, as European Alliance for Responsible R&D and Affordable Medicines, we had the opportunity since day one of the pandemic to stress that an effective response requires that all these necessary medical tools are free of charge at the point of delivery, particularly for vulnerable populations, and that the EU institutions and national governments should incorporate collective pro-public safeguards, such as transparency regarding public contributions, accessibility and affordability clauses, and non-exclusive licenses for exploitation of end results products in current and future funding calls and investment. This is what we have said on March 2020. So since the beginning of the pandemic, double messages were spread among the European leaders. On one hand, they talked about vaccines as public goods, and in several occasions, the European Commission talked about assisting the WHO TAP initiative. When the first signs of developing vaccines arrived, the European Commission established for the first time in our history a joint procurement mechanism in order to discuss with the Western industry as a united market. That was, according to my point of view, that was the one and only achievement of the European Commission during the pandemic, which unfortunately was applied only for vaccines. Instead of highlighting to the pharmaceutical industry that the European taxpayers take over the risk of the research and development for those new medical tools that we were expecting, prices and the equivalence between public investment and public return was not at all transparent, and the issue of TRIPS flexibilities found strong opposition among EU leaders, even at the time that USA's President Joe Biden declared in favor. As a result, today, EU countries are vaccinated in a 75%, but they struggle with variants, calling for boosts every 3 to 6 months, and having their countries till today under restrictions. A Eurobarometer survey that was published last Thursday reveals that only 53% of respondents say that they approve or they partially approve of how the EU handled the vaccination strategy. And this percentage, I think that it should make political leaders to reflect. In March 2022, just a month ago, came up the latest initiative of the European Commission, the USA, India, and South Africa that decided at last to talk about TRIPS flexibilities. This is an initiative that comes after the one of the BRICS countries, Brazil, Russia, India, China, and South Africa, to launch the BRICS Vaccine R&D Center, having as main objective to share best practices and strengthen practical cooperation in research, development, production, and distribution of vaccines. We just need to understand that BRICS countries account for the 40% of the global population. So as European civil society organizations, we welcome this late shift of the European leadership on TRIPS flexibilities, even though Germany, practically as always, is still reluctant. We just think that this initiative should be applied for all medical tools and not only on vaccines, as it was also discussed in the first panel. And as Dimitri Einikel, a friend of mine from the MSF, says, we call all members of the World Trade Organization to remain vigilant to the fact that this leaked text that we have seen contains considerable limitations and needs to be urgently improved. Now, concerning actions within the EU region, we call all of you to consider supporting our European citizens campaign called No Profit on the Pandemic. I will share with you the links in the chat, by signing in the official website in order to reach our goal of 1 million signatures. I want to inform you that today, Medicines du Monde has submitted 2 third-party patent observations against 2 patent applications on COVID-19 vaccines by BioNTech at the European Patent Office. They strongly believe that both of those patents would be underserved since BioNTech has directly implemented existing knowledge from already developed vaccines for other coronaviruses and mRNA vaccines. Thus, this is an inventive step that it's clearly missing since the science has been already there. Finally, we ask you to navigate in the website I'm going to share with you in the chat. This is a website delivered by HIA and share it with lawmakers, policymakers, researchers, and the public about how they can use TRIPS flexibilities to improve access to patent medical tools. The information here is currently limited to the European Union member states and focuses on the use of compulsory licensing, but geographically and topic scope will be wider over time. Solidarity, coming to an end, I want to tell you that solidarity, I think it is a misused concept, and usually it's confused with charity. We are far from introducing structural changes in the system and far from understanding our common challenges as humanity, being currently divided and suffering from the illness of personal interests, according to wealthy people, and regional interests, according to wealthy countries. Personally, I think that this global consciousness, so much needed to overcome global challenges as pandemics, wars, starvation, climate crisis, energy crisis, nuclear catastrophes, meaningless lives, and other things, this global consciousness is going to take shape sooner or later, as otherwise we have no future in this planet. So I keep telling myself to stay positive, be patient, and work hard, proclaiming human rights and human living conditions for everyone, independently of racial, social, sexual, religious, economic, or other status. Thank you very much for the opportunity.
Thank you very much, Marianela, for your very excellent and practical consideration that you presented. This is actually a way forward already. Pradeep, you can take over the floor now. Thank you very much.
Okay, thank you. Thank you, Becky. Thank you, colleagues. We are running late. So I'll just run through the plan that we have for GCAP for the year. In fact, we wanted to get some inputs from you, but that doesn't seem possible now. So At GCAP, we already have been kind of working for last full year from February, March last year on the issue of vaccine inequality, demanding people's vaccine, free and universal vaccination, and demanding certainly the intellectual property waiver. Last year, I'm not talking about last year, this year itself, till in last 3 months, January, February, March, we've done some activities. We did the social media action and GCAP Asia, PBA Asia Twitter storm on March 8th, the International Women's Day. Then we did embassy actions. We sent letters demanding trips over to the rich country embassies from African countries, and did press conferences from 8 countries in Africa. As part of the second year anniversary of the pandemic on March 11. Then we did side event at the Asia Regional Forum on Sustainable Development, discussed vaccine inequality in Asia. There are some of the media coverages we got in last 3 months. Many more, I just am giving you a snapshot here. So broad areas of intervention that we are planning this year are research analysis campaign, physical and online actions, alliance building, awareness building, advocacy, engagement with the media. I should tell you that these mega actions are planned, in fact, at the Asia level, because we have committed funding for GCAP Asia, but for GCAP Africa, GCAP Latin America, we do not have funding. So we'll try to do as much as possible in line of the plans that I'm sharing, mostly for Asia, but we'll definitely try to do some actions, though at a lesser scale at the global level. For other regions, we do not have committed funding, but we are expecting some funding from different sources, including People's Vaccine Alliance. Hopefully, Maja probably is taking note of it. So on research and analysis, we will be doing country level and regional level position papers, certainly in 8 countries, 8 and 9 countries in Asia, 7 or 8 countries in Asia. Based on that, we'll issue statements at the regional and national level to our governments, sharing with them the existing inequality that many of our colleagues have already shared, that the last mile approach, the last mile vaccination remains as a challenge in most of the Asian countries. So we'll be issuing statements to the governments. It's part of our advocacy agenda. And then certainly demanding to support openly the TRIPS waiver. There are certain developing countries who are fence-sitters. So they should come out in open and support the TRIPS waiver. Proposal put forward by India and South Africa. Alliance building, we are already part of People's Vaccine Alliance. The global level, in Asia level, we are also kind of in the leadership position. And then, yeah, at the national levels, we will be doing planning national meetings with civil society organizations to form a large network of on the alliance on vaccines. It's already active in Nepal, India, Pakistan, and Philippines and other countries. So awareness building would this webinar itself is a part of awareness building mechanism for us, and we'll be certainly doing some communications during the time. This part is extremely important. We are scheduled to meet some of the members of European Parliament, some of the commissioners of European Commission, to influence the Europe voice, particularly UK and Germany, who are blocking the TRIPS waiver across. These are the countries who are influencing the EU decision, and then EU is opposing the TRIPS waiver. Now, the one they have said is extremely weak version of what we are demanding, that is not going to do any good. We'll also be engaging with the civil society in Belgium, Germany, and UK to kind of suggest them to come with us. That already we are doing under the banner of PBA. In Singapore and Japan, things have changed a little bit. We are already engaged with the government there, but we'll continue to engage with the members of parliament and other officials there to change their stat from a fence-sitter to support the TRIPS waiver. We'll be doing a series of advocacy with the national governments, member of parliament, the officials, to declare this as a people's vaccine, and to essentially the important part of that is implementation, to see that last mile vaccination is done. We'll be doing rigorous media engagement through press conferences, meet the editors and host television debates. We already are doing in India and Pakistan, in other countries. So we'll be doing off and online actions during key moments. International Women's Day that we did, regional forum on sustainable development, that's something we already did, high level political forum. Then during September 25, the Global Week of Action, which is a power-packed action week for GCAP and other colleagues at the Action for Sustainable Development, will be raising this issue of trips waiver, vaccine inequality. These moments we'll be doing people's assembly in national level, regional level, and global level, where we'll be highlighting this among ourselves and with the media and the members of parliament wherever possible. And key WTO moments, key G20 moments, key G7 moments. So we'll be doing all those. We'll be bringing, as Maja told, we'll be bringing short case studies in forms of videos, print form, and in highlight as much as possible in our social media. That's all. Thank you. Becky?
Thank you, Pradeep. I'm sorry, my internet is wavering at this point. But I'd like to thank everyone who participated. I'm very happy to have gotten back in touch with everyone. This work is surely very important for all of us to build our networks, not only in our respective regions, but across the different regions where GCAP is present. I think it's the right time really to push our governments to be more accountable with the kinds of funds they have been using up for COVID. Now they're saying that it is a recovery period, but vaccination and all these structural issues related to vaccination and the production of diagnostics and the availability and access to this important means of fighting COVID has not yet been fulfilled even at this point. So it's I think high time that we intensify not only our efforts amongst ourselves as networks, but also work at the local level, at the national level, because this is where it matters. No, we keep on saying that these people have been marginalized and have not been reached, but we should also make the governments at the local level accountable, because I think it is only by making them accountable that they will realize that these people are actually needing the assistance they have been deprived of for the longest time. So
Becky,
I'm sorry, I cannot put on my video.
That's okay. If you can give just 2 minutes to Maja to explain us what the one word for pharma is. That's an important campaign that we're doing. Maybe just 2 minutes, you can, Maja, explain us.
Yes, Masa, please go ahead.
Thank you very much, Becky, and thank you, Pradeep. So this month is the annual shareholder meeting of Pfizer and Moderna. The People's Vaccine, in collaboration with GCAP and others, is working on 2 actions that lead into each other. The first one is that we're asking people to please record a voice note to these 2 pharmaceutical companies that are literally making a killing as we speak. I have something here that tells me that Pfizer, BioNTech, and Moderna, the most profitable vaccine companies, are together making over $4 million an hour on these COVID-19 vaccines. So we have a small kind of an automated system where you can send a WhatsApp message or record a WhatsApp message to Pfizer or Moderna, and we're encouraging that you end with a word of your choice. There is a video that I could show you, but since we're out of time, I will share the link. But basically you record a voice note and you end it with a word, whatever word, whether it's greedy, selfish, racist, shocking, whatever you want to call them. Maybe for those of you who have more colorful language, maybe save some of the more colorful words. So the idea is for the recording, we're going to put all of those together And on April 28th, we will be at their shareholder meetings in the places where they have offices and playing those messages in compiled format. And we also have a video that we will be sharing. So it's a combination of actions. I'm going to put in the chat here. There is a, I'm going to see if I can put it in the chat. There's something that you can, if all of you have WhatsApp on your phone, it's very easy. You can also do it on your computer. It's very simple. You record, and then please keep in touch with Pradeep and Kavengo and others about the actions that will be taking place in the countries. Pradeep, it's not allowing me to upload the image on here. So what I'll do is I'm going to send you the link to the People's Vaccine Alliance website where you can see the video of the co-chair explaining what we would like you to do. You can also hear her recording. You can hear her recording, and then you can record yours, you know, say whatever you want to say to Pfizer or Moderna, and then end it with the word of your choice of how you would describe them. And we'll be compiling those. We really want them to be from all over the world. We already have 140 recordings. If you would like to record them in your own language, you can. Those might not be saved, played at the physical action, because some people might not understand them, but we'll use those on social media. So if you'd like to record in Greek or in Spanish or in French or in another language, please feel free, and we will use those on social media. But for the in-person events, we'll be focused on English. So please do participate in that. And I'll send the links, Pradeep, so you can share them with everyone. Thank you.
Okay, thank you. Thank you, Maja. Time to, in fact, say thanks to all of you. Thanks to the speakers, guest speakers, I would say, Maja, Raskishore, and Professor Gupta for enlightening us on this. It's extremely important. It's a technical subject. We need to be enlightened to transform that into action. Thanks, colleagues from the regional GCAP and PBA LAC for your presentations. And thanks, Becky, for moderation. Thanks all of you colleagues for participation, and our friends who, for interpreter friends, Hector and all of the other colleagues. Can we switch on our camera for a photo, and then we say goodbye to each other? And looking forward to have solid actions in coming months. Thank you. One photo, please. Switch on your camera. And such is. Perfect. Thank you very much. Bye-bye, friends. Thanks, Becky. Thanks, colleagues.
Thank you so much.
Thank you. Bye-bye.
Thank you. Bye.